Okay, I think we're going to go ahead and get started. Welcome, everyone, to the Timothy A. Johnson Medical Scholar Seminar. For today, we are going to hear from Dr. Cruz, but just a little bit of background about the origins of this seminar series. It's named, as many of you know, for our founding dean of research here at the School of Medicine, who was really passionate about the idea of embedding science within the early years of medical school curriculum. And so part of that is this seminar series where we get to bring in fabulous people like Dr. Cruz. And so I'm going to give you just a little bit of an intro about her. So this isn't actually her first time in Virginia. She's from Virginia. She went to UVA, but we let her in anyway. It's okay. After that, she went to medical school at St. Louis University, and then on to Johns Hopkins, where she did her training, her residency, her fellowship in nephrology. And then she stayed on at Johns Hopkins, where she's currently associate professor in the Department of Medicine, but she also does a whole bunch of other things, and I'm only going to hit a few of those highlights. So she's associate vice chair within the Department of Medicine for diversity and inclusion. She's also associate director for research development at their Center for Health Equity. And that's just a few of the different things that she's doing already at Johns Hopkins. She's only been out of fellowship for about a decade, and it's amazing all of the things that she's accomplished in just that short amount of time. She's already serving as a frequent reviewer for NIH study sections, so she's evaluating what gets funded and where the research directions are going to go. She's on a number of editorial boards for a lot of the nephrology journals. And then really importantly, in my opinion, is the fact that she is training already the next generation. So she's mentoring numbers of students and post-baccalaureate students in doing research. And so that's a key part of her role in training her future collaborators, I think we would all hope. So she's actually the founder and director of Johns Hopkins' doctoral diversity program. But in addition to that, she does an immense amount of research. So if you look at her CV, she's been publishing prolifically for the past several years. And the focus, as you all probably know, is on chronic kidney disease. So she's collaborating across the nation and even internationally to look at chronic kidney disease and approaches to manage it. And a lot of these are epidemiological studies, and we had the opportunity to discuss, those of you who are students and some of the facilitators had the chance to discuss some of those papers. What I think is really compelling, what I think you're going to find really interesting about this seminar, is the movement from the study that she did that we discussed, where we were looking at the DASH diet and how that interacts with social determinants of health. I don't know about you guys' groups, but in our group, a lot of the discussion is, well, what do we do with this information? There's this robust study, and we have some of these interesting correlations, but what do you do about that? How can you impact and take those results? And so she currently has a grant with the NIH, in close collaboration with the NIH, to develop an intervention that's based on the findings that came out of that paper. So I think we're going to hear a little bit about that today, about how you take that information, actually translate it into something that's going to impact patient outcomes. Because as you all know, that's the end of the story, right, is impacting patient outcomes. And so in addition to all the research and leadership she does, she's still seeing patients, because that's what's motivating her, I'm going to assume. So I'm not going to speak anymore, but I'm really excited to hear what we're going to hear from Dr. Cruz today. Thank you very much for being here.
Thank you so much for that really warm introduction. I very much appreciate you all allowing a Wahoo to be here, although there are a few here, though. There's a couple of Wahoos, right? I heard from a few. Yeah, Wahoo Wah to you in the back. Okay. So great. So I'm so honored to be here with you all today, and have really enjoyed the time that I've gotten to spend with the students, and as well as some of the wonderful faculty that I had an opportunity to meet with this morning. I am, as you've heard, someone who has had a career focused on chronic kidney disease, and in particular, this idea of helping us move closer to a place of kidney health equity. If any of you tweet, please do follow me on Twitter and join in on the conversation that some of us are having around this topic. And so I will get started. So during our time together today, I just have 3 objectives that I hope to cover, and I don't have a ton of slides because I hope to leave some time at the end for some questions and hopefully some discussion around some of these topics. The first thing, though, that I hope to do is to provide an overview of chronic kidney disease. I tried not to assume that when I speak to audiences that are not 100% nephrologists, that everyone is sort of knowledgeable about CKD. So we'll do that. I'll go on to then also highlight health equity as a framework for thinking about chronic kidney disease, and highlight some of the potential root causes of some of the inequities or disparities, as a similar term, in chronic kidney disease. And then finally, as was alluded to earlier, I'll share some of the ongoing work that my colleagues and I are doing to try to address some of these inequities. So first, just by way of definition, so when we think about health equity, it means that everyone has a fair and just opportunity to be healthier. And so in order to be at a place of health equity, this requires removing obstacles to health that exist, including things like poverty, discrimination, and the consequences of those factors. And it also includes removing a sense of powerlessness and lack of access to good jobs that provide fair pay, quality education, housing, safe environments, as well as health care. And this is a definition provided by the Robert Wood Johnson Foundation. I think that hopefully all of us can agree that a focus on health equity is a moral thing to do, and perhaps some would say a right and a just thing to do. But I think an important thing that I'll mention really here at the outset is, and something that we don't talk about a lot, but that is that health inequities are actually very costly. When we look at data from the United States, this is from the U.S. Department of Health and Human Services, we find that health inequities or health disparities account for $50 billion a year of the expenditures that come out of our Department of Health and Human Services, meaning that if health were more equitable in our country, we would save $50 billion a year. And 30% of the medical expenses that racial and ethnic minorities incur are actually costs that have stemmed from health inequities. And then important to particularly some of the ideas that we're going to be talking about today, and some of the work my colleagues and I have done, is to note that the U.S. actually spends less on social services than other countries, and it's actually the only country that spends more on healthcare services, so things like hospitalization and clinical care, than it does on social services. And we're going to touch on some of those types of social services here, and this is when we think about, when I say that the U.S. spends more on healthcare services and social services, this is as a percentage of our gross domestic product. Okay, so I promised an overview of chronic kidney disease. So when we think about CKD, as we generally abbreviate it, it's generally conceptualized as existing across a continuum. And by this I mean that most individuals have normal kidney function, but then there are a subset of those who have, or some individuals who have increased risk of developing chronic kidney disease. And these are going to include people who have other chronic conditions like diabetes or hypertension that are clinical risk factors for developing chronic kidney disease. Of that group, there are some who will develop kidney damage that we usually assess through looking for protein in the urine, or albuminuria or proteinuria. There are some individuals who will develop a decrease in their kidney function, so a decrease in their kidney's ability to clear toxins in the bloodstream. And then there are some that will develop end-stage kidney disease. So this is the box, this sort of space that's in this box. This is the group that we are referring to when we talk about chronic kidney disease. And there are, in the United States, there are, has a little timer on it. In the United States, there are over 700,000 people who are treated for end-stage kidney disease. This is going to be with transplantation or dialysis. But there are actually more than 40 million people, or 15% of the U.S. population, that have this earlier, bless you, that have this earlier kidney disease. And while for that group, this greater than 40 million, The overwhelming majority of them will actually never go on to develop end-stage kidney disease. Rather, most of them will actually die prior to developing end-stage kidney disease, and they'll die largely from cardiovascular disease. And that makes a lot of the shared risk factors for kidney disease very akin to those that are similar to what we see in cardiovascular disease. Okay, so when we think about kidney disease, inequities or disparities are profound in the setting of kidney disease. And these are just a few that I want to highlight for you. So African Americans, while making up 13% of the US population, they comprise about a third of those people in the US who have kidney failure, including those who are either treated with transplantation or dialysis. Hispanics and Native Americans are 2 times as likely as Caucasians to develop kidney failure. And low-income individuals are twice as likely as those who have high incomes to develop kidney failure. African Americans, Hispanics, and Asian Americans are less likely to receive living donor kidney transplants than are whites. And kidneys that come from living donors are sort of the optimal type of kidney to be transplanted, as they tend to work faster and work longer than those kidneys that come from deceased donors. And awareness of chronic kidney disease is low, which is sort of overall, when we look at snapshots of the overall US population, some estimates are that only around 10% of people, if you take everyone who has chronic kidney disease in the United States, only about 10% actually know they have it. And that is a big challenge for us from the standpoint of prevention. But it is particularly low even among groups who have a high risk of kidney disease, including some of those that I allude to in this slide. So a number of different frameworks have been put forward to help us think about the relationship between being at some sort of social disadvantage, whether that is due to being from a racial or ethnic minority group, or having a low income, or a number of other different sort of aspects that place individuals at a social disadvantage. A number of different frameworks have been put forward to sort of connect that to chronic kidney disease. This is one that I like, that I'll share with you today, because I think it really highlights what I think are 3 big basket areas that I think are the main drivers that we see when we think about kidney disease. So the first one that I'll point to is on your far right here, which is one that I think many of us would probably think about, that for sure, that if a person does not have insurance, or they have a limited amount of health insurance, that then they're going to have decreased access to health care, and maybe as a result of not having insurance, maybe they have some access, but they may not utilize all the healthcare services that would be recommended for them. And then they could certainly go on and then develop issues in terms of not having prevention of their chronic kidney disease risk factors, including things like diabetes and hypertension are 2 leading causes of chronic kidney disease in the US, right? And so ultimately they can go on and develop CKD, progression of CKD, and they can also develop end-stage renal disease and also suffer premature mortality. I think these other 2 areas are ones that we may think about less often. In the middle is the issue of discrimination, where we know that for many socially disadvantaged groups, they experience discrimination, including in settings that are important to their health care, which we'll touch on some of the work my colleagues and I have done in this space. But we know from other literature that the experience of discrimination can lead to chronic stressors and also maladaptive health behaviors, so things like substance abuse, smoking, physical inactivity. This can ultimately also lead to sort of this tree of issues that ultimately lead to chronic kidney disease and progression of that disease. And then finally, on the far left is this idea of residential segregation. And by this, I mean that because of historical design of our country in many ways, many groups, many socially disadvantaged groups have been partitioned away from certain goods and services that would be health promoting for them. And they have also been sort of situated in settings where they have poor educational systems, poor housing, and from that, a number of different challenges can flow that ultimately, again, can lead to kidney disease. And so in our time together today, what I thought I would share with you would be some of the work that my colleagues have done in touching on these 3 areas. So touching on poor housing, discrimination, and then finally we'll spend the balance of our time, probably about half of our time together, on this issue of poor nutrition, which I know for the medical students you all read some of my work on that area. Okay, so I'm thinking about discrimination. So when it comes to work around perceived discrimination, there have been, really for the last few decades, there has been work published connecting the experience of sort of perceiving discrimination with a number of different health outcomes, in particular blood pressure levels or hypertension, as well as there's a lot of work that's been done connecting that experience to heart disease. My colleagues and I, and you'll see, I like pictures, so you'll see me highlight a number of particularly the mentees that I've had that have worked with me on some of these projects. But we were able to provide the first study that looked at the connection between perceived discrimination and kidney disease. And so in this study, we looked at self-reported perceptions of both racial and gender discrimination. And these were, the way that this was assessed was we were looking at the perception of discrimination in these 5 distinct situations. And so those situations were in the setting of at school, so when trying to get an education, in the setting of trying to get a job, at work, at home as well, and then also when getting medical care. And so the survey that was applied sort of asked questions about each of those 5 situations. And then also we applied a general measure of discrimination that has been studied in a number of other settings. And just to give you sort of the main finding, what we found was that among white women, a high experience of discrimination was associated with having a lower baseline level of kidney function. So they had lower estimated glomerular filtration rate than those individuals than white women who did not have, who had lower levels of experience of discrimination. And we also found among African American women that both perceived racial and gender discrimination had a relationship with them having a lower level of follow-up kidney function. So we actually looked over time. So we had kind of a baseline set of data that we looked at, and then we also looked at after about 5 years of follow-up in this particular study, the Handle study, we looked to see their kidney function, and we found this relationship. And so there are, for a number of particularly low-income older adults, many of them face home environmental challenges to their challenges that affect their ability to function at home and their ability to sort of to what's called age in place, or sort of not get placed in a nursing home or nursing facility. And so some of the work of my colleague, Dr. Sarah Zanton, who's a professor in our School of Nursing at Hopkins, she developed a program called CAPABLE, and CAPABLE stands for Community Aging in Place, Advancing Better Living for Elders. And this is a program that's, again, it's for low-income older adults who often have these home environmental risks. And the program is focused on the strengths and deficits that these older adults have, particularly when thinking about their ability to complete their self-care. So their activities of daily living and their instrumental activities of daily living. So things like being able to cook their own food, bathe themselves, dress themselves. And the program, I think, is an interesting one. I hope you'll find it interesting. It is a 5-month program, and it's home-based. The program involves a nurse who goes into the homes of the participants and does an assessment and kind of works with them to set goals around what that older adult would like to be able to do. And then it involves also an assessment from an occupational therapist who goes in and does, works with the participant. And the occupational therapist observes the home of the individual participant and identifies modifications that might be made to the home to support their functioning, and then provides a work order to a handyman who actually comes in and provides, makes up to $1,300 worth of home repairs to support the functioning of that individual in their home. So notably, this body of work, which is now in 5 health systems and 20 hospitals across the country, has been found to lead to a 7 times return on investment in subsequent savings. So by this meaning that the total cost of the program is about $3,000, and it has led to a $21,000 savings. And so it's really sort of spreading across the country. Dr. Zanton published this paper just this last year in JAMA Internal Medicine, which was a clinical trial of this program in 300 low-income older adults who had disability, sort of showing that there was an improvement in their level of disability. As you might imagine, if we can improve disability, then we can certainly keep patients out of the hospital and keep them from having to be placed in nursing homes, both of which are very distressing for them to experience as well as being costly. So why am I sharing this? We were very interested in applying this program capable to the end-stage renal disease population, in particular the dialysis population. And so we developed, and this is again in partnership with Dr. Zanton, we developed SOCIABLE, this is my proudest study acronym, so I hope that you admire it. And SOCIABLE stands for Seniors Optimizing Community Integration, Advancing Better Living with End-Stage Renal Disease. So what we did, you like that? Some people like it, okay. So so what we did here is that we knew a bit about Capable because that had been done in the general older adult population, but we needed to know how we might be able to apply this to the end-stage renal disease, the dialysis population of older adults, with a particular focus again on those who had low socioeconomic status. So we conducted some focus groups, and this is an approach. I know you all are learning about different research methods. This is an approach of it's an approach called intervention mapping. So if you want to develop a new intervention, you have to start with, particularly clinical intervention, you want to start with understanding the population that you want to intervene upon, if you will. And so we started with these focus groups. This is a qualitative research approach. And we recruited some low SES older adults who were treated with hemodialysis and also had some functional limitations. And in those focus groups, what came out of them is we identified a number of different themes around some of the challenges that they were facing, and also some of what their hopes were. One of them was that they were just by and large facing overwhelming fatigue, particularly on the days that they had dialysis. So after they finished their dialysis treatments, they felt just exhausted, and just when they got home, really felt like they couldn't do much around their home. There was also what they shared, which was, I have to say, somewhat heartbreaking when I was listening to the audio recordings from these focus groups. As a nephrologist that takes care of patients treated with dialysis, is many of the patients in these focus groups expressed that after they developed kidney failure and a need for dialysis, they felt like their social networks, including their family members, kind of stopped inviting them to things. They were sort of socially excluded, and they didn't know if it was because maybe their family members were worried that they wouldn't be able to make it through all of the family activity and would have to be taken back home, or that there's just something that they felt like they would not be able to participate or shouldn't be able to participate in those activities. And so they ultimately, over time, reported that they were just being excluded from even being invited from these sorts of things. And then the focus group participants also said they had a real strong desire to live independently, that they didn't want to be placed in a nursing home, they wanted to stay in their homes. And so in the context of this, we pilot tested the Capable-like intervention with a sort of an enhancement around, particularly this area around fatigue, and having our occupational therapists in the study kind of work with these participants around things that they could do to sort of preserve energy. There actually are activities that are energy preserving. And what we found was noted improvements in both their physical and their social functioning in this short pilot study. So our conclusion was that home-based interventions of this kind are feasible and they are acceptable to the dialysis patient population, and they could potentially lead to favorable outcomes here for this group. And so we're going to be in the coming months applying for funding to do a larger scale version of this intervention. And so we talked, I know I talked with some of the medical students earlier about some of the different types of dialysis. So a person who is in need of dialysis for kidney failure, that dialysis can be done in a center, in-center hemodialysis, where they have to come in 3 times a week and get their treatments. Dialysis can also be done at home. And there's one type that uses the blood, home hemodialysis, and there's another type that uses the fluid of the peritoneal cavity, or peritoneal dialysis, in order to sort of exchange electrolytes and fluids and to keep those in balance for people who have kidney failure. So one issue is, you might imagine that a person who is homeless I think most of us would imagine that they would have face a number of difficulties, for sure, doing dialysis at home, and might even face a lot of challenges coming regularly to a dialysis center to undergo their dialysis treatments. And so with a mentee of mine, Dr. Tessa Novick, who prior to medical school was a social worker and has a deep interest in the social determinants of health, including homelessness, we put together this opinion piece that was published in JAMA Internal Medicine now a couple of years ago, where we really called out what we think is something that should be explored for the end-stage renal disease population, and that is the provision of supportive housing. For some health conditions, including there are some programs for people with HIV, for example, who if they are experiencing homelessness, they can actually get permanent supportive housing to actually support their ability to receive their treatments and the like. And so we believe that we were trying to sort of lean on policymakers around this to initially, first we need to actually just start capturing more information about homelessness among the dialysis population, but also with a hope to move towards this provision of permanent supportive housing. And so I touched on a couple of these things, particularly when thinking about the work with Dr. Zanton and the home-based intervention with the handyman. But more and more through my work and that of others, I'm coming to realize that to move us towards kidney health equity, what we are going to have to do is demonstrate value in sort of these interventional approaches that we have. And by that, and I don't know if you can see the shading, but by that meaning that we have to demonstrate that something has a high benefit, but at a low cost. And so I think I can just see in the audience here people who are going to be doing really wonderful things now and in the future around this. But I think work that is leaning towards health equity has to show this. And so with that in mind, I want to share with you some of the work we've been doing around nutrition. And so I know that this was touched on among the medical students in particular, and perhaps the graduate students as well, but how many of you are familiar with the DASH diet? This is the food part of the, okay, most of you. How many of you were familiar with the DASH diet before you were asked to read the paper that... Okay, good. All right, that's a good. All right, so still most of you, so that's great. So the DASH diet, or the Dietary Approaches to Stop Hypertension diet. It is not a weight loss diet. It is a dietary pattern that has been shown through a number of studies to be effective at, particularly at lowering blood pressure. It has also been shown to actually have some protective relationships with cardiovascular outcomes, so meaning that people who eat in this way are less likely to develop cardiovascular disease, and also there's a body of literature around the DASH diet and diabetes. So just a reminder maybe for some who are familiar with it around what the DASH diet includes. So it is a dietary pattern that's rich in whole grains, fruits and vegetables, low-fat dairy foods, nuts, seeds, and legumes, and includes modest amounts of meat, poultry, and fish, and has very limited amounts of sweets and fats and oils. So one of the things that's interesting, and this is for my nephrology colleagues in the room in particular, is that the DASH diet and the Mediterranean diet, which I think probably maybe more have heard of the Mediterranean diet, right, are both low in what's called dietary acid load. So as it turns out, every food that we consume exists somewhere on this continuum, right? And so meaning every food that we consume is either going to be on this end of the spectrum, meaning that It is leading to the kidneys having to handle a high load of acid, right? And then there's some foods that are going to lead to a more basic environment for the kidney, right? So where it's a sort of a less acidic environment. So every single food. And so this diagram or this sort of way of calculating dietary acid load of common foods was developed by Drs. Rimmer and Manns. And as I mentioned, every food exists on this continuum. So on this acid producing end are things like, are mostly animal-based foods, so including hard and processed cheeses, and also most meats. And then on the base producing side are foods like raisins and spinach. And those who saw me with my Dunkin' Donuts cup this morning will know that I'm very happy that coffee is closer on this end. Coffee is actually quite low in dietary acid load. Okay, so, all right, so every food. So why does this matter? So for when it comes to kidney disease and a number of other conditions, we're learning more and more about the effect of high dietary acid load. So we know that, and I'll start with these things on the outer side. So we know that that it can lead to more bone resorption and also ultimately to fracture, so weaker bones and ultimately to fracture. We know that high dietary acid load also has a role in muscle catabolism, including then the development of sort of decaying muscles or sarcopenia and ultimately frailty there in the middle, or there on the end there. But in the middle, when we think about the kidneys, high dietary acid load has what we think to be quite a number of different effects. On this side, so it can lead to increased ammoniogenesis, which ultimately leads to complement activation. And so for those learning about complement, you'll know that certainly can be injurious, and then that can lead to progressive kidney disease. And on this side, it by leading to a more acidic environment in the kidney itself can lead to increases in some hormones that ultimately promote fibrosis, so angiotensin 2, endothelin 1, and aldosterone. And so all of these together, we think, can certainly play a role in progression of chronic kidney disease. And so again, so my colleagues and I, in sort of with this as thinking about diet and how it relates to kidney disease, we've over the last several years have performed a number of different studies, really trying to draw a line between these different dietary patterns and kidney outcomes. And so I believe, actually none of these are the paper that you all read. These that I'm showing you here are all longitudinal studies where we were looking, for example, at the relationship between a DASH-like diet and the risk of kidney function declining over time. And we found that it was protective. So people who followed a more DASH-like diet were less likely to have declines in their kidney function. We looked at the dietary acid load as well. And we found that those who had lower levels of dietary acid load, meaning they were following a dietary pattern that was more rich in fruits and vegetables, that those individuals were less likely to develop incident chronic kidney disease or new chronic kidney disease, right? So these are people that, to start with, were free of kidney disease, and then we were looking to see if they developed it over time. We found that those that had low dietary acid load were less likely to do so. And then we've also done studies among people already with some degree of chronic kidney disease and found that if they are following a dietary pattern that's lower in dietary acid load or more closely like a DASH-like diet, they were less likely to develop end-stage renal disease. Okay, so, and for that, I think someone asked me if I work with PhDs. These are all PhDs. So I work very closely with people with PhDs. So great, and so if you're wondering then, so hopefully I've made the case that a dietary pattern that is high in fruits and vegetables, that it's lower in dietary acid load and more closely similar to a DASH-like pattern is good for the kidneys, right? We'd call it kidney-friendly. So why doesn't everyone follow this kidney-friendly diet? So some of the things that I think are important to think about are taste. You know, some people find these, what I think we could agree upon would be sort of less healthy foods to be more tasty. People have particular preferences around their foods. Many have been following a certain habit around their way of eating that can be hard to break. And there are cultural influences. Certain foods and food groups are more common among people with certain cultural backgrounds. And then finally, though, I think it's important to think about market pressures and how they influence the dietary patterns that people have. And by that, what I mean is what is being sold and where is it being sold and how is it being marketed. There's some work that's been done looking at even just billboards and where and around different foods and where they're placed in cities and which sort of cities they are placed in, right? And which areas, which communities, those sorts of things are advertised in. And so each of these are probably factors that play a role in the reasons that we see behind why not everyone is eating in this way. So one reason, though, I think that's important to consider is this idea of food insecurity. So how many have heard of food insecurity? Everyone. Again, how many have heard of it before they read a couple of my papers? Okay. All right. Hey, all right. So great. So food insecurity. So it's defined as a sort of limited ability to afford nutritionally adequate foods. And it tracks fairly closely with income level, in that people who have lower incomes are certainly at greater risk of experiencing food insecurity, although not everyone with a low income experiences food insecurity. In the United States, food insecurity affects 13% of households, or more than 40 million people. And in every county around the United States, there are individuals who are affected by food insecurity. When it comes to food insecurity, the way that, for those that study it, myself included, what we're looking at is we look at these different questions. So on this right-hand side, we ask questions in these different using these different survey instruments about things like whether over a specified amount of time, like in the past year, did you ever worry about the food that you had running out before you could get enough money to buy more food, right? One of the more common questions that is asked in some of these surveys is, have you ever, in the last 12 months, did you ever skip a meal or reduce the size of your meal because you didn't have enough money to afford more food? And I think importantly, and this is sort of the comment that's here on the left-hand side, when we assess food insecurity of an individual person, and I'll share with you some data from the clinical setting as well, or with an individual patient, what we're seeing is sort of one snapshot, and it likely in that instance represents important trade-offs that an individual is making around their basic needs. So it could be that for some people they may be food insecure at the moment, but that is because they just spent their money on paying their medical bills or paying their electric bill, right? So it's sort of, a lot of times it's more so representing trade-offs that are being made in order to take care of some basic needs. So when it comes to food insecurity and chronic disease, it has been associated with a greater prevalence of a number of different diet-related chronic conditions, or diet-sensitive chronic conditions, including diabetes. We know that people who are food insecure and have a diagnosis of diabetes, they are more likely to have poor control of their glycemia. They're more likely to have a worse glycemic control. They're also more likely to get hospitalized, particularly at the end of the month. For those that are receiving supplemental nutrition assistance, or the food stamp, previously called the food stamp program. For those that are receiving that benefit, what we see is a spike in hospitalizations for people with diabetes towards the end of the month when the money from that benefit may be running out. There's a relationship between food insecurity and hypertension, as well as a relationship with obesity. Does the obesity one surprise you? So we're talking about food, right? So some people are shaking their head. So I'll tell you that around the world, so food insecurity is really a global problem. In low and middle income countries, food insecurity can lead to actual frank malnutrition, where people are very thin and maybe even experiencing wasting. But in the United States, it more commonly leads to obesity, and that is because of the types of foods that when people can't afford, when they have difficulty affording food overall, the types of foods that they tend to buy are going to be cheaper, more energy-dense foods that are often higher in calories and more obesogenic. And so, but when it comes to kidney disease, food insecurity and chronic kidney disease is a fairly understudied area. And so, after having done a cross-sectional study looking at food insecurity and chronic kidney disease, my colleague, Dr. Tanushree Banerjee, who's at UC San Francisco, she led this study where we looked at people who already had chronic kidney disease, so they already had a glomerular filtration rate that was under 60, right? So they had impaired kidney function. And this is using data from the National Health and Nutrition Examination Survey. So this is a nationally representative population that we were looking at. And just to give you the main finding here, what we found was that for the group that in red here who had food insecurity, over time they were more, over 10 years of follow-up, they were more likely to develop end-stage renal disease than those who did not have food insecurity or were not experiencing food insecurity. When we went on in that same study to adjust for, to account for some of the potential confounders, I know there's learning about confounders going on here, things like demographic factors, age and gender, race, and as well as some clinical factors like diabetes and hypertension. What we found was that when we, in that final model here, when we found it, when we adjusted for nutritional factors, and by nutritional factors we mean the total number of calories that were being consumed by the individuals each day, their body mass index, and also their dietary acid load, so hearkening back to some slides ago, what we found was that we were able to adjust away the statistical significance of our findings in those earlier models, which was exciting to us, and I'll tell you why. That suggested that if the relationship between food insecurity and progression of chronic kidney disease to end-stage renal disease could be in part explained by nutritional factors, if we could intervene in the space of nutrition for these individuals, then perhaps we could slow their progression to end-stage renal disease. Okay. So another major, though, issue when it comes to a barrier to healthy eating for socially disadvantaged individuals is this idea or this issue of healthy food availability. So this is a study that was done now more than a decade ago by a colleague of mine at Johns Hopkins, Dr. Manuel Franco, where he, through work at, we have a center at Hopkins called the Center for a Livable Future. And among many other things, that center, every 2 years, they send out a group of enthusiastic research assistants who go out with a clipboard, and they go to every food outlet in Baltimore City and every food outlet in Baltimore County. And they assess the availability of healthy foods in each of those food outlets. Okay, and they're using an index called the Healthy Food Availability Index. And I'll show you, so if you want to take a trip with me to Baltimore, there was one medical student I met who's from Baltimore, but this box is Baltimore City, and then out here is Baltimore County. Johns Hopkins is kind of right in like this area here. And what they found in this study was that they were looking at both the neighborhood racial composition, so with the neighborhoods that had predominantly black inhabitants being shaded in white here, and those that were predominantly white in terms of their race in that community, they're shaded in gray here. And they were also looking at the availability of healthy foods. So the larger the green circle, the more availability of healthy foods. And so hopefully you can appreciate that those large green circles mostly overlay the darker gray shaded areas. And indeed, the main finding of the study was that there was a greater amount of healthy food available in those communities that were predominantly white and also higher income communities as well.
What about the area, there's 4 large green
Right here?
dots?
Yep.
Left.
Yep.
What is
So this is northwest Baltimore County. This is a fairly affluent, predominantly African American community. Yep. Okay, so we were interested, again, in this idea of thinking about sort of intervention mapping. Like if you want to do an intervention, and I hope you're getting the idea that I am headed with this epidemiologic work to trying to develop an intervention. So again, if you want to do an intervention, you need to understand the population that you want to design that intervention for. And so we did this, again, a qualitative study, a focus group study with Dr. Amber Johnson, who is now on cardiology faculty at University of Pittsburgh. This was a study where we recruited African American individuals who had a first-degree family member with kidney failure. So first-degree family member on dialysis or who had received a transplant. And the people that we recruited themselves had a clinical risk factor for for kidney disease. So they had either diabetes, hypertension, or obesity. And also they had some index of low socioeconomic status. Either they didn't finish high school, or they indicated they had a low income or were unemployed. And basically we asked them, we said, if someone wanted to help you to make a dietary change that might help you to not develop kidney failure like your family member, we asked them a lot of different questions, like what are some of the barriers that would need to be overcome? What are some of the issues that would need to be addressed? And some of the things that came out include this first one, where one participant or several participants highlighted that healthy foods are expensive and they're unavailable in certain neighborhoods. So one of the participants said, and what we have in our neighborhoods and most low-income neighborhoods is fast food restaurants everywhere. You hardly see a farmer's market or fresh produce stand or even fresh produce in the supermarket. And as soon as you walk in the market, the first thing you see is cakes, cookies, chips, cereal with loads of sugar. And so they were highlighting what is I think the situation for a number of food outlets that are in low-income communities. The participants also highlighted that unhealthy foods are more convenient to prepare or to access, and that these unhealthy dietary practices have been a lifelong habit for them, and that they perceive that it would be difficult to break those habits. So we wanted to also think about, what are some of the factors to think about in the clinical setting when we are thinking about how these issues of food insecurity and healthy food availability sort of show up when we're seeing patients. And so one of the things I think that was important to think about was this was from a report that I had the opportunity to participate in and developing through the National Academy of Medicine, where they developed we as a committee developed a set of measures, social and behavioral domains that would be important to include in the electronic health record. And so one of those things that that there was a sort of large body of evidence to support was this idea of financial resource strain, this question around financial resource strain. So what is that? So the question is, a short question, it's how hard is it for you to pay for the very basics like food, housing, medical care, and heat? And then they sort of rate it on this scale. So this was what was recommended through this committee, was that this type of information be collected and that it would live in the electronic health record and stay there, so that the next clinician that sees that patient would see this information and know that this is something that this individual patient is dealing with. There was a systematic review done a few years ago looking at U.S. healthcare entity-based programs and how they screen for patients with food insecurity. And the majority of these healthcare systems used a question I alluded to earlier, which is the hunger vital signs screener questions that include within the past 12 months, did you worry whether your food would run out before you got money to buy more, right? And then this issue of a similar thing in terms of that the food didn't last. And what they would do then for most of these healthcare systems is that more than half of them would track those food insecurity screening questions in the patient's electronic health record, as was recommended by that National Academy of Medicine report. And so then if you're wondering what they do with that information, so for many of these then healthcare systems, they would some of them would refer those patients that screened as having food insecurity. They would refer them to a list of different food resources like food banks, soup kitchens, or to get set up for receiving federal benefits, including the Supplemental Nutrition Assistance Program. Some of them would connect the patients with a patient navigator, like a case manager or social worker who would do the connection with the food resources. Some of them had food pharmacies on site. How many have heard of that? A food pharmacy? A few of you, yeah. So these are sort of set up to provide immediate needs for patients. So the idea being that you see a patient in clinic, you identify that they're having some challenges in terms of accessing food. And you do a couple of things. One, send them straight to sort of get really all the types of foods that might be available. Some have gone as far as to do what is noted in that final bullet there about the sort of prescription programs, where they actually provide these like food sort of prescriptions, where they say, okay, you have diabetes. These are the types of foods that you should get from this food pharmacy. And then others have set up programs that provide medically tailored foods. And here, this is specific to a patient who may have a number of different nutritional restrictions or dietary restrictions based upon their set of health conditions, and then the food is tailored. The food that gets delivered, usually it gets delivered to them to their homes, or they come and pick it up. It's tailored to that individual patient's needs. And so a number of health systems are doing this. And if you wonder, like, this seems like a lot to do, they're doing this because I'm sure there's altruism underneath there, but they're also doing it because it actually helps their bottom line. They're finding that that food insecurity is a cost multiplier. They're finding that people who are food insecure they're admitted to the hospital. This has been documented in the literature, but they're admitted to the hospital more often. They're readmitted more often. And so if they can address this social need, they're finding that then they can keep those patients out of the hospital, which helps them to drive costs down. So. That's what's going on in a number of different systems. So I think most of you are familiar with the SNAP benefit, the Supplemental Nutrition Assistance Program. So as you probably know, it provides what is the equivalent of $30 a week of money that can be used to, or I should say, money, something like money, right? Sort of a voucher that can be used at most food outlets. And this study looked at whether people who received the SNAP benefit over time, and we'll go into a little bit more detail here. This is over like a period of about a decade, compared to those who could have received it because they were eligible for it from an income standpoint, right? They compared it to that group, and then compared to people who had higher levels of income. And therefore wouldn't qualify for receiving the SNAP benefit, and many could argue wouldn't need to receive this benefit. And what they were looking at is, well, how good are the diets of these individuals? And so this is, I'll point to this at the bottom, and they were looking at not just how good is the diet, but how has the quality of the diet changed over time. And what they found was basically the diet is the proportion who had, based on sort of American Heart Association guidelines around this, the proportion with a poor diet was still pretty high. So almost nearly so it was about 55% of those in the SNAP program had poor diets. About 40% of those in the income eligible group had poor diets, and even the higher income individuals were doing a little bit better, especially in recent years. But still still a substantial proportion of people that are sort of not hitting what would be considered a target as far as diet quality. But I think the important thing is to note that the quality of the diet, even with this provision, that these individuals still, a large proportion of them still had poor diet quality. And so my colleagues and I, now I mentioned the study title that I was proud of. I'm proud of this article title as well. So, so a colleague and I, we published an editorial about this article, where what we tried to do is we highlighted that the provision of money itself is likely not enough to lead to the sorts of changes in terms of the quality of diet that individuals at risk for cardiovascular disease, kidney disease, and the like, that just the provision of money, even the provision of food by itself without guidance around what to purchase is probably not going to lead us very far. And that's something that we tried to highlight in this article. So leading then to, in the final minutes, to sort of where we are as far as trying to intervene in this space. So we developed and have ongoing a clinical trial called the 5+ Nuts and Beans for Kidneys trial. And it is building upon a successful pilot study that my colleague Dr. Pete Miller led, where in that 8-week pilot study, they employed this approach to coaching African Americans with hypertension, African Americans who also were from low socioeconomic backgrounds, coaching them around following a DASH-like diet, and also providing fruits, vegetables, nuts, and beans to the tune of $30 a week, worth of these types of foods, really with an emphasis on increasing the amount of potassium that was in those foods, in the foods that they were consuming. And they successfully were able to show that they could change the diets of these individuals, and there was sort of a signal towards it improving blood pressure, although it was it was an 8-week study. So interestingly, in that pilot, the people that were included, there was a subset of them that had already had evidence of chronic kidney disease. There was a subset they were leaking protein in their urine. They had albuminuria. And that population, that group that did have albuminuria, actually showed an improvement in albuminuria over those 8 weeks, a statistically significant improvement. And that plus a number of other studies around diet and kidney outcomes that have been performed by some colleagues around the country led us to provide a foundation and a justification for applying for funding through the NIH to then do a 12-month study of predominantly low-income African Americans with both hypertension and albuminuria, and glomerular filtration rates of at least 30. So they were 30 and above in terms of their GFR. And we're testing a similar approach as what was done in the pilot. And we provide these $30 a week worth of fruits, vegetables, nuts, and beans. They get delivered to. They can either the participants can either pick them up at our sort of community location, or we can, if they have difficulty getting in for that, we actually have a courier that will deliver it to their home. The main outcome of our study. After this, so they get the food for 4 months, and then along with weekly coaching around incorporating these types of foods into their diet, and then for 8 months they get after that they get just the coaching without the provision of food. And what we're looking at is as our outcomes are reduction in the albuminuria, and we're also looking as a secondary outcome at reductions in blood pressure. This is a community-based participatory research study, which is these are types of studies that are co-developed and really co-implemented with community partners. We work with a number of these partners, these stakeholders that are highlighted here, including our grocer, ShopRite, which is our grocer partner here, and the Baltimore City Health Department also is partnering with us as well. So that's sort of the story there. So I want to summarize here, and then hopefully we'll have a few minutes for questions. What I hopefully have highlighted is that health equity means that everyone has a fair and just opportunity to be healthier. Inequities or disparities in chronic kidney disease are quite profound. I believe that we'll achieve kidney health equity through a number of different approaches, including addressing needs that actually may exist outside of healthcare, so including some of these social needs that we touched on, engaging multiple different stakeholders, including patients, in developing these interventions, and then focusing on demonstrating value, as I said, in order to sort of make the business case, if you will, for addressing health equity. I want to acknowledge the participants of the studies that I presented, as well as my funding sources and my colleagues. And then I hate to do it, but I have to give a shameless plug for those that are interested in kind of this topic of health disparities. My colleague, Dr. Zanton, and I recently launched a podcast that's called Aging Fast and Slow, where we talk about different societal structures that influence why some individuals age more rapidly, more aggressively than others, and others age more gently. And the first episode just aired on Wednesday, so feel free to subscribe wherever you download podcasts. Please feel free to subscribe to us. And I thank you, and I'm happy to take questions. Please, in the back there. Yeah, first.
So, prior to going to medical school, I did research on the stuff in DC with telemedicine connections, CKD, diabetes, so a lot of these kind of chronic disease.
Oh, great. Uh-huh.
One of my questions is one of the primary care attendings at Unity Healthcare who worked with us always said that one of the problems is always just dealing with this perpetual state of chaos, right, in these neighborhoods and these environments. And so I kind of want to dig into your clinician mind a little bit. Is there anything in the exam room that you can kind of connect with on an individual patient level, just to sort of drive these messages home to your individual patients, given all the other factors that they have to contend with?
Yeah, so, hopefully everyone heard the question. So what I would say is definitely approaching any sort of clinical encounter and clinical experience with a lot of humility, and by that with a particular a particular emphasis on not assuming that you know that person's circumstances. And so I think and some of the work that I didn't have an opportunity to share today that we've been doing around like trying to understand the types of communication that happens in the context of a visit, a clinical visit. As far as discussions around diet, we've done some work with primary care, in the primary care setting, so where we audio recorded the visits between primary care clinicians and their African American patients with hypertension and chronic kidney disease, right? And we were listening and sort of transcribing the discussions that were had around diet. And what we were particularly listening for was what you were alluding to, which is that querying about the context under which they are sort of making decisions and what their environment is that might support or detract from their ability to sort of make the sort of behavior changes that we often make. We found those to be rare. We found those sort of queries to be rare. I think that's a space for greater development. I don't know. I mean, with so many things that all of us as physicians and other clinicians are trying to cover in the context of a visit, I think there's room for skill building around how to incorporate that in. But I would say starting with humility. And when you sort of make a recommendation, never assume that person has the supports and is living in a context that's going to make it readily possible for them to do what you're telling them. And so I think that if you start from there, then you won't go wrong. So, okay, there's a question right here.
Actually, it kind of leads into my question of when you were referring to the last time you said that you coached participants.
Yeah.
What do you mean by coaching?
Yeah, so thanks for that. So the coaching. So in our study, so we 5 plus nuts and beans for kidneys. So we have she's like a health coach is how we've trained her. So she's trained by our lead dietitian in our study. She's a research dietitian who has trained our study coach, as well as we have a number of other team members on our research team that have been trained in motivational interviewing. So as a coaching style. So as opposed to being prescriptive and directive, like you go and reduce the salt in your diet, ma'am. It's more of tell me about the types of foods that you like to eat. What do you know about things that might be healthy for you, given that you have high blood pressure? What do you know? And then sort of working and it's a sort of a way of walking people in an incremental way with sort of small goals, right? To sort of help support them making behavior change. But it's a I think a well-studied approach including among dietitians, but not one that we use so much out really, not so much that physicians use, but it's been found in sort of in the behavioral health literature to be an effective way to counsel people or coach people. Yeah. Question? I'm going to go here and then I'm going to come back. Yeah, right next to.
Question about the same stuff.
Oh, okay.
So you said that it was like the 12 weeks with the coaching and the food, and then 8.
So maybe I'll go back. So 4 months.
4 months.
Wherein on a weekly basis they get food delivered and they have weekly coaching calls, so they're coached on a weekly basis in those 4 months. And then in the last 8 months of the study, no more food delivery. This is for the intervention group, by the way. So no more food delivery, but they continue to have coaching. So initially every other week and then on a monthly basis. So that's what the intervention group gets. The usual care group or control group gets in the first 4 months. They get an equivalent amount of food provision in the form of a gift card. I skipped over this. They get a gift card to the same grocer for the same amount, right? But they don't get the coaching and they don't get the guidance around following a DASH-like diet. And we're doing assessments of our outcomes both at baseline, at 1 month, 4 months, and 12 months. So we'll be able to sort of see, we really, and a colleague of mine said, basically you're doing 2 different studies. You're doing one where you're looking at what is the effect of the provision of food and coaching, and then another of what is the effect of coaching by itself, right? And so what we expect to see is hopefully some improvements some reduction in terms of the albuminuria in those initial 4 months. We expect to see some regression after they are not receiving the food, but I think if we're able to sustain it to a level that's lower than where they started at baseline, I think it could be a powerful thing to demonstrate what the effect of both the food provision as well as the coaching might be. So, yeah.
My question actually was for like the future of that intervention. How do you see it like being scaled out? And like where the funding is going to come from? That kind of question.
Yeah. Thanks for that. So we're fortunate that we're not the only investigators sort of looking at this in different ways. There's a faculty member at the University of California, San Francisco, Dr. Hilary Seligman, who's really been a leader in the space of food insecurity, that she and some colleagues, and there's some others, some in New York as well, who are doing work where looking at different ways of incentivizing healthy eating. So we talked about SNAP, right? So Dr. Seligman has done some work where they are giving an additional $5 per week to participants who are receiving the SNAP benefit, but they're saying that $5 can only be spent on fruits and vegetables. And they're seeing if that, and her main sort of chronic disease of focus for her work is diabetes. And so in that particular study, they're looking at people with diabetes and doing that kind of work. And so my hope is that if all of us really are finding similar things, that it is that we have to do a couple things. We have to sort of provide this sort of provision, but also guidance around the foods that people are eating, that we can make a case for national policy. That's one hope. I think in the interim, we might, maybe even before that, continue to inform some of the health systems that I alluded to that are rolling out some programs like this on their, what is a smaller scale than the federal level, but that we may be able to inform some of that. Yep. And then Sham, and then I'm going to come right here.
Yeah, so my question is actually tied into that with the scale of like how you can expand these kinds of interventions.
Yeah.
Specifically, you're talking about your at Johns Hopkins and colleagues at UCSF, these big urban centers.
Mhm.
I went back to that map of food insecurity.
Yeah, it's everywhere. Yeah.
How do you kind of tackle the issue of geography where people just can't get
Yeah.
to grocery stores and things like that?
Yeah, and part of one of the things that we've been thinking about, some large corporations that you probably purchase things from, they're not paying me, so I'm not going to advertise for them, but some that even have drones and can deliver things and own grocery stores now. So there's food delivery potential from some of those sorts of outlets, and some are using things like that. Like one of my colleagues is doing a study looking at a similar approach, but looking at people with gout, and they're actually delivering, using that company, delivering to the homes in that way. So those are some of the different things. I'm actually also working with, we haven't successfully gotten a grant for this yet, but working with some of our colleagues in systems engineering at Johns Hopkins, at our Whiting School of Engineering, looking at things like robot delivery into communities and drone delivery, and like thinking of different ways to get food to areas that are food deserts. But yeah, and I do think more work needs to be done. Thinking about this in rural communities as well, because we can say, for sure these participants in our study, they live in food deserts, but the width of that desert is not as great as in some rural communities across the country. So I think there's a real need for that sort of work as well. Yeah. I don't know where to go. I don't know. Do you want maybe here? The cow? Yep. And then we'll get around. We'll keep walking across the room.
So, so the things we've been talking about have primarily been about getting people access to healthy foods. But you also identified preparing those foods as a primary
Sure.
issue that patients face. How do you see that kind of fitting into this interventional model?
Yeah, absolutely. So that's a great question. So we do in our study, we do provide like some recipes and things. We give them each week when they come and pick up their groceries, or we deliver the groceries to them. In the bag, we have kind of like a tip sheet of like how do you incorporate more beans into your diet, or nuts and that type of thing, and some recipes. We haven't like included cooking classes and things in the context of our study. There are particularly some health systems that do some of that, as well as some organizations. The American Heart Association, for example, has some local, in some of their locales across the country, they provide cooking courses as part of their programming. But it hasn't been a particular focus of ours, but I think it's an important thing for the future. Yeah. right behind you there. Yeah.
My
And then I'll go
question's
back.
a little bit more like on the federal level as well, but
Sure.
probably a little bit more specific to urban populations. I'm wondering, in the public health world, is there any talk about like counter advertising? So like, for example, I see billboards and advertisements all the time that says smoking can kill you, but I don't see anything that says Coca-Cola or McDonald's, et cetera, can kill you. And do you think, like, especially in some of these low-income communities where, like they said, there's just fast food everywhere, that's all there is, do you think that kind of advertising could drive some of those out and bring healthy grocery stores or like farming subsidies, stuff like that in?
Yeah, I think there's a role for that type of advertising. I think so. I think a probably more efficient way to achieve what I think you're getting at is influencing like full service grocery stores moving into some food deserts, right? Would be more at the sort of regulatory level. So thinking about like tax benefits and things of that sort that would might influence their coming in. And so I think for these, some of the arguments that some of these grocers make is that they obviously they have to think through the full business model. If you move into a low income community and you're an expensive store, right? You can move there, and yes, that may open up opportunity for those community members to come there. But if it's expensive, they can't afford it anyway. So they have to think through what is going to be their bottom line. And so yes, their bottom line though can be affected by, like, well, maybe we can reduce your the taxes that you have to pay for being in this community. So I think both are answers. I think the more efficient way may be at the regulatory sort of the legislative level to make that happen. Yeah, I'm going to go behind. Oh, I don't know what the time.
I know everybody has a lot of questions. It's a really interesting topic. It looks like Dr. Learman wants to say one more thing.
I do too, yeah. Thank you so much. This has been so spectacular. And for those of you I haven't met in the Biomedical program, I'm Lee Learman, the dean of the medical school. I've had a long interest in the value of healthcare and health disparities. And I think as we've heard the conversation today about food deserts, about community-based efforts, about federally funded research to study this, I think it's important to remember one important context. If you look globally at high-resource countries and how much they spend on healthcare, and the value that they get back from that, value meaning what the outcomes in exchange, you probably know that the United States spends the most and has the poorest outcomes. So hopefully you know that. One thing I learned a couple of years ago from a really nice international study was that in almost all of the other countries on the high-resource country list, for each dollar that they spend on healthcare, and they're getting really good value for, they spend $2 on social services.
Social needs, yeah.
So they get really good value for that dollar in the context of spending $2 on social services. Some of the things you just talked about today. Does anyone know in the United States, for each dollar we spend on healthcare, where we get very poor value from that dollar, how much we spend on healthcare? Social services, pardon me. 50 cents. 50 cents. Now, that's an association. That's an association, not cause and effect. But the context of the high value care we see in other countries, the context of that is $2 for each dollar spent on social services. One example of a social service that I've heard about, to our first question, that works in terms of understanding community context for health is something called the nurse-family partnerships that have been focused in specific communities that have been shown to have recurrent problems in Medicaid programs throughout multiple states. As those problems cost more and more, it then becomes financially beneficial to send a nurse. Nurses are expensive. To send a nurse out to the community to actually be in homes and help people understand how to implement health behaviors in the context of their lives. It's as an adjunct to what they're hearing from their physician. So again, as the cost of care goes up, we can afford those sorts of things, but they're happening now in a very ad hoc way, not a very organized way. But I just want to thank you. You brought so many important topics today, and the conversation that followed was just so incredibly valuable. So let me join our laconic and thank you so much.